Welcome to the 2013 Sedation Peer-to-Peer Podcast. This educational activity is sponsored by the France Foundation and is supported by an educational grant from Hospira. Today's discussion is presented by Dr. Riker and Ms. Klein. Let's listen in.
My name is Kate Klein. I'm an acute care nurse practitioner at Cleveland Clinic in the Neurological Intensive Care Unit in Cleveland, Ohio. And I'd like to talk to you about some strategies of assessing pain in the intensive care unit and across all types of intensive care units. Pain is a very important feature for all of us to assess. I think one of the things is just having an awareness that there are physiologic as well as psychological consequences of pain. The physiologic response really being sort of the stressors on the physical self of pain, and then the psychological impacts or the long-term effects psychologically when we talk about PTSD or, that sort of stress response that's long-term. I think just having an awareness that pain can really have an impact on both physiologic and psychological. And then also looking at, I think it's important to look at the ethical considerations. For nursing, it's when we look at the American Nurses Association and their code of ethics, one of the first principles in their code of ethics is to treat this pain, and everybody has the right to be pain-free. And this, along with the International Association for the Study of Pain, came out with. They made a statement acknowledging that access to pain management really is a fundamental human right. And I think that's something that's really important to take into consideration. And Rich, I'm not sure about, I'm sure this goes on in your unit too, but we really try to instill in our nurses and other clinicians that patients deserve to have a right to be pain-free. And for us, that can be difficult sometimes because in the neurological intensive care unit, because we want to take care of their pain, but we don't want to mask something that might be going on neurologically, so like a deterioration.
No, I think you're right on target, Kate. My name is Rich Riker. I'm a pulmonary and critical care and neuro ICU physician at Maine Medical Center in Portland, Maine. And I agree 100%, Kate. The challenge of appropriate dosing of analgesic medication really depends on an appropriate assessment of pain. I remember one of the shocking papers I read by Payan back in 2009 in anesthesiology. It was part of a pain study they did called Deloria, kind of a clever title for a pain study. But what they looked at was on the second day in the ICU, was pain assessed? Yes or no? And what they found is that in the subset of patients in whom pain was assessed, they had a lower incidence of sedation dosing and had an associated reduction in ICU length of stay, mechanical ventilation duration, ventilator-associated pneumonia, and a trend towards reduced mortality. And when I first read that, I thought, that how can that be? Just assessing pain, having a reduction in all of these resource utilization. And I thought, well, maybe it's just a marker that the better ICUs assess pain more often, and I think that's probably true. But then in talking with friends about it, I understood that if you know pain is present, you're probably going to treat it with an analgesic medicine as opposed to a patient who may be restless and not having pain who would get maybe a sedative. On the other hand, a patient who's having pain and gets sedative, you're not treating the real problem. More commonly, I think, are patients who may be restless or hypertensive and not having pain, and maybe instead of getting fentanyl or morphine for their hypertension, they need a beta blocker or some other antihypertensive therapy. So it may be that knowing whether pain is present or not allows you to really target more accurately what that therapy needs to be to best treat that. So it comes back again to the importance of assessment of pain.
Right. I think what's also important that we try to instill in all of our clinicians is proxy reporting, finding out from families, making families very much a part of the pain assessment, because patients can have pain from previous injury or some chronic pain issues. If they're lying there in the ICU bed and they have the breathing tube in, and their whole system has just been hit really hard by critical illness, and they're having a difficult time communicating about, imagine if you're lying there and you have back pain, and this was a chronic pain, this is a chronic issue, and nobody really knows about that. And it's really important to have the family there to help with that assessment and let everybody know that this particular patient has some chronic pain issues, and so already they're, aside from their critical illness or any procedure that's going on, they already have some pain issues. And then looking at how did they manage that pain prior to coming in? What worked well for them? What didn't work well for them?
Yeah, I think that's a great point, Kate. And, one of the things that we often will do for our patients who end up getting admitted to the ICU, especially if altered mental status is part of their presentation, is to stop all those medications and not anticipating, as you mentioned, that, without that baseline control of their pain medication being given, they're probably having excruciating pain completely separate from what's going on with their acute illness. That's a great point. We know that what is considered the gold standard in pain assessment is the patient self-report. And that is often a real challenge in ICU patients. And I know especially in your neuro ICU, it's an especially challenging issue. I wondered if you could talk about that, Kate.
For our patients, there's most of them, when they initially come in, are unable, their brain has been so stunned by the injury that so many of them are not able to communicate. But neurologic injury in itself can cause some real barriers to communications. If somebody, say they come in and they have a right middle cerebral artery occlusion, so now the left side of their brain is somewhat knocked out, if you will. So they have a left MCA stroke, and that's exactly where their language center is. They may not necessarily be able to verbally say what's going on. A lot of these patients have some word-finding difficulty as it is, and some of them also have what we call receptive aphasia. They're not receiving the information in. So that the language barrier that goes along with neurologic injury is a real challenge. Sometimes you can, for a patient that is somewhat awake but just can't find those words because their language center has been affected by the brain injury, then it's really difficult, and we see them frustrated when we ask a question or we ask them to sort of describe what's going on for them, that they can't express it. So it's getting really creative, really, with finding a ways or using the standard scale that we have for assessing for pain. And for some people who are the nonverbal pain scale is what we use, implementing that along with just picking up some other cues. I understand that some of these behavioral scales and the nonverbal pain scales that are used, really they only have moderate correlation really with a patient being able to really give a self-report of what their pain is. But I think in a combination of using a validated scale along with picking up some of these other behavioral cues that a patient has is important. And we find that we have to use as many types of assessments, whether that be, we definitely use the tool, but we also look for other signs as well. It's challenging for patients to be able to communicate when their brain has been impacted so much by such an injury.
Yeah, I think even in our non-neurologic population, it remains challenging. Intubated patients, sedated patients, I know other issues that confound their communication skills, if they've got delirium or whatnot. And even among our extubated patients, it remains a real challenge. Mm-hmm. As much as we can, what we try to do as our gold standard, as our first line, if we can, is to get them to tell us whether they're having pain. And what we try to do with that is ask a yes or no question that they don't have to speak. They can shake their head yes or no. Are you having pain? And if we can get them to do that, then trying to get them to quantify it in that 0 to 10 scale. And boy, it's so amazing to me how poor we are as surrogate estimators. We're doing a dyspnea study right now where we're having patients rate their dyspnea on the ventilator and having nurses and respiratory therapists and physicians assess what they think the patient's dyspnea is. And I can tell you in the first 10 patients we've done, there's not a great correlation between the patient answer and all the clinicians. So I don't think we're very good at guessing that. And there's similar data that shows that not only are nurses and physicians not very good at it, family members aren't so good either. So doing whatever we need to try to get the patient to be able to tell us their level of pain. And that includes lightening their sedation enough so that they can communicate with us. As part of the 2013 pain, agitation, and delirium guideline process, we had the pleasure of working with Celine Jolinas, who is out of McGill University in Montreal and has done a tremendous amount of work on pain assessment. But what she showed us is that if you look at that gold standard of patient self-report and then look at vital signs, hypertension and tachycardia in particular, there's not a good correlation at all. And patients in the ICU have so many other reasons why they may be tachycardic and hypertensive. We're treating that vital sign with opiates or analgesics thinking it's pain when in fact it isn't. We're missing the boat, and we're probably prolonging their time on the ventilator and in the ICU. I think, as you mentioned, Kate, the behavioral pain scales are things that we have started to use more often.
Mm-hmm. Yeah, looking through that, when I look at the behavior pain scale along with the critical care observation tool, those are, as my understanding, those are the two that are the most valid tools, and I'm not sure if either of those are what you use if the patient isn't able to verbally tell you whether they have pain or not. In your unit, do you use either one of the pain scales?
Yeah, so we're in the process now of trying to look at both the CPOT and the BPS to try to determine which one we want to use. They kind of get used a little bit interchangeably now, and we've not decided on a single one. One of the problems is that one's more popular in one of the units and another in another unit, and we're trying to get a standard single pain assessment tool that we'll use across all ICU locations. But, talking about these behavior-based pain scales, I think I agree that they are not strongly correlated with patient self-report, but they're better than guessing. And they're very similar. The BPS, which was developed by Pan, uses 3 different parameters: the facial expression, upper limb position, and compliance with ventilation. And within each of those 3 areas, patients get scored between 1 and 4. So you would think that the most relaxed facial expression and no movement of the upper limbs and tolerating movement while ventilated would be the least amount of pain. And then looking at those 3 areas again, a grimacing facial expression and permanently retracted upper limb position and unable to synchronize well with the ventilator would be the most pain behavior. And when you look at the CPOT, the critical care pain observation tool, it has very similar assessments. That again was developed by Celine Gelinas and published in 2006, looking at facial expression, body movements, muscle tension, and then either compliance with the ventilator if it's an intubated patient or vocalization if they're extubated. And again, the trends that we would look for in a more comfortable patient would be no muscular tension in their facial expression and no need to move at all for body movement, no resistance to passive movement for muscle tension, and easy ventilation or talking in a normal tone or without sound. Whereas the more painful behaviors would be eyelids tightly closed and frowning or orbit tightening for facial expression, pulling at tubes or attempting to sit up or, moving limbs or thrashing about for body movements, strong resistance to passive movements or inability to complete them for muscle tension, and then again, asynchrony with the ventilator or crying or sobbing. I think it really gives us a framework to try to look at a patient who's showing different behaviors and use a quantitative tool to try to quantify that. And I think it has really helped us in that subset of patients that we can't get to assess their own pain, even by lightening their sedation and really working to try to get there. I think it gives us a good tool to assess pain.
Yeah, I think the behavior pain scale along with the critical care pain observation tool, we're challenged with that simply because some of those things like the facial expressions, or for patients that have neurologic impairment, things like facial expression or certain body movement, they may be plegic or paretic on either side, so trying to assess some of those body movements and facial expressions if they have either a left MCA or right MCA stroke, and we're relying on facial expression, that gets to be a little bit difficult. There's actually the Nociception Coma scale, which we're going to be looking at in terms of utilizing this, and this was a pain scale that was developed really according to behaviors generally considered during assessment of non-communicative patients that are maybe in a coma or they're minimally responsive. There's a paper in Pain in 2010 by Carolyn, I'm not sure if I'm pronouncing her name correctly, Snakers or Snackers. Anyway, they looked at the Nociception Coma scale in vegetative state or minimally conscious state in coma survivors, and they actually found that that was a pretty valid tool for measuring pain, similar to some other validated tools that also measured nociception. So it's interesting because how the scale works is that noxious painful stimuli, either through nail bed pressure or other, and then you're looking at motor response. Do they have localization to that noxious stimuli or flexion withdrawal? These are some of the common things that we do just in a neuro exam, that we elicit some noxious stimuli and see what kind of response that they have. So this scale actually is more in line with the neurological exam that the nurses commonly do at the bedside. So there is a verbal response too for some of the patients. Obviously they can't verbalize, but if there's an attempt to verbalize or if there's some groaning that goes on when that painful stimuli is put onto them. Or a visual response, is there fixation, are there eye movements, is there a startled response when that nail bed, maybe putting nail bed pressure on, or a facial expression, is there a grimace, is there a cry, is there none at all? So I really like this tool because it's much more in line with the type of neurological exam that we commonly do, and I think it would be a good tool to transition into the nurse's care because it's so similar to what they already do.
Well, that sounds great. I think the more we can minimize the additional assessments that are required and really incorporate important information from our standard assessment tools, that will be a very helpful step for us all.
Yeah. I think that neurologic injury in the patients that are in our ICU, we're really finding that this is a unique population, that some of the tools and investigations that have taken place and included patients that are in a medical, surgical, or cardiac ICU, that those types of, whether it be assessments or interventions, you can't necessarily just apply them to patients with neurologic injuries. They're proving to have their own unique set of symptoms or their own unique way in that they are able to or not able to express themselves. So it's interesting. There's not a lot out there in studies that have included patients with neurologic injury. So I think this is an area that is really in need of looking into and how our patients with all of their neurologic injury and how unique that can present itself and to our patients, that a lot of work needs to be done in that area.
Yeah, I agree, Kate. And, hopefully recognizing the significant incidence of pain among ICU patients of all kinds, medical, surgical, neurologic, and the consequences of inadequately treated pain to their recoveries, these tools to try to have patients self-report their pain if possible, and if not, using a validated scale, whether that's the behavioral pain scale or the critical care pain observation tool or the Nociception Coma scale or some other validated tool that meshes well with our patient population, hopefully allows us to better assess pain that our patients are having, and that's a critical first step before we can treat that pain.
Yes, and I think that keeping in mind that the impact that pain can have on patients long term, that exactly what you're saying, Rich, I think it's very important to have the best means in being able to identify pain and then also treating it, because the impact that this can have on patients long term. There's patients who recall pain and other traumatic situations in the ICU. Looking at one paper, there was 82% of ICU patients that were discharged from the ICU but still in the intensive care unit recalled their pain during their time in the ICU. And even after they were discharged, still 82% of post-surgical patients identified pain as the most traumatic memory of their ICU experience. And then going even further into 6 months post their time in the ICU, 17 to 38% still remember pain as very traumatic. So looking at things like PTSD or even higher incidence of chronic pain, 38% have been associated with the pain that they experienced in the ICU. And then even lower health-related quality of life. 21% in the same study, the 21% of the patients had lower health-related quality of life after the 6 months out from their ICU stay in that experience. So I think it's really important that what we do in the short term in caring for patients, doing the assessments and treating them, really impacts patients long term. So I think anything that we can do in the short term, like pain management in the short term, is going to have a huge impact on patients long term.
This concludes the discussion. We would like to thank Dr. Riker and Ms. Klein for their contributions and continued support. Thank you for listening. To receive credit, please complete the evaluation form found on the website www.sedation-cme.org.